Certainly, if somebody is on a tyrosine kinase inhibitor and experiences a very significant burden of adverse events, one could look a little bit closer at what those adverse events are and perhaps tailor a different option to the patient's needs. For example, if someone has a lot of hypertension or a lot of hand-foot skin reaction, and you do not feel that you're able to handle that very appropriately with dose reduction, mitigation of adverse events, and discontinuation, you might find it reasonable to switch to a different agent for that purpose. So one of these agents, of course, is cabozantinib. Cabozantinib is a multi-target TKI. It affects the VEGF pathways, VEGF 1, 2, and 3. It also affects MET, and it also certainly affects other pathways, including MET and AXL, which are important potentially in preventing spread and metastasis of disease, and potentially are implicated in resistance to the effects of drugs like sorafenib. Cabozantinib was studied in a large study called Celestial in second line. When compared to placebo, these were patients that were able to receive sorafenib in first line. So every patient who was in that study had received sorafenib first. But the study had fairly generous inclusion-exclusion criteria in that patients could have received a second-line agent that could include even an IO treatment. And there were even a small number of patients which had a third line of treatment before being enrolled in Celestial. Celestial basically has its data reported as of 2018 in the New England Journal of Medicine, and the Celestial data show at the planned interim analysis a median overall survival of 10.2 months with cabozantinib and 8 months with placebo for a hazard ratio of 0.76. Remind you, this is in second line. A progression-free survival with cabo was 5.2 months and 1.9 months with placebo. This is for all comers, including patients who had multiple lines of therapy, which was a significant proportion of these patients. The advantages and disadvantages of prescribing this drug versus other drugs in part have to do with mechanistic components in terms of the pathways that they target and how these may, at least in theory, circumvent resistance, although we do not have specific clinical evidence that supports this without any shadow of a doubt. But at least mechanistically, one could see how in second line a drug that targets MET and AXL might be able to help with that. The other aspects that are, of course, important are the sequencing of a TKI after initiation of therapy with another TKI and the ability to tolerate that initial treatment, which obviously is built into the inclusion criteria of Celestial. The primary efficacy data in second line in terms of overall survival and progression-free survival have been described to you just now. And in addition to what I said, I think it's important to understand that in the setting of patients who only had one line of therapy with sorafenib, which is pretty much everybody had to have at least sorafenib in first line, these are in a subset analysis more differentially increased compared to just the overall cohort of patients. Cabozantinib, like every other drug, is not by any means free of adverse events. The adverse events that are hallmarks of TKIs are certainly present here. These include hand-foot skin reaction, hypertension, and fatigue. And these certainly need to be aggressively managed by an experienced physician who is very familiar with the adverse events of TKI in order to be able to maintain patients on therapy and hopefully achieve the same type of survival benefit in second line that a patient that was enrolled in the Celestial trial was able to benefit from. Hand-foot skin reaction for anyone who's prescribed TKI should be a staple adverse event that we manage in early stages or low degrees of severity with topicals such as 5% urea cream, avoiding repetitive motion in areas of high impact, applying treatments to any callosities or corns or other problems in the feet and the hands, which would be usually delivered by a podiatrist. But when the severity of these toxicities is more pronounced, such as when you have partial or full thickness ulceration of fingers or toes, typically dose interruption or dose discontinuation for an interval period of time until these toxicities subsides is the way to go. And in some cases, if that does not resolve, discontinuation of the drug is really the only way to do this. Hypertension is typically managed with an antihypertensive and sometimes with dose reduction or dose discontinuation if this does not work. My go-to antihypertensive in the setting of cabozantinib treatment is a calcium channel blocker, either initiation or increase in dose if the patient's already hypertensive. And I would say that many patients are already hypertensive when they have these toxicities because they have a setup for them. And fatigue is an overwhelming at times and debilitating class effect of all TKIs. And so if you are treating a patient with a TKI, you have to be able to manage this effectively. At times with dose reduction from, let's say, 60 to 40 in the case of cabozantinib. At other times, you need to dose interrupt in order to allow the patient to recover. In the setting of liver disease in general and HCC also, increasing physical activity seems to be an effective treatment for fatigue in some patients. Certainly identifying any mental health burdens that could be overlying this, such as depression, is important to diagnose and treat. And there have been some small trials looking at other interventions for fatigue, which I very selectively offer to patients, including acupuncture and other alternative and complementary therapies. There are certainly some patients who have a high AFP where we see some tyrosine kinase inhibitor treatment do less well. That does not appear to be so much the case with cabozantinib, which is a good thing. I'll remind this audience that there is a treatment in second line specifically approved for patients who have an AFP greater than 400 nanograms per milliliter, and that's ramucirumab. That restriction in approval does not apply, though, to cabozantinib, which is approved at all AFP levels, but certainly is something to think about and follow over time in those patients.